17. Let's get into it. Very common as well. Introduction. Stroke is the 5th leading cause of death and the leading cause of adult disability in the United States. It's common in the geriatric population. Other contributing factors for stroke include family history and race. Treatments are available, but these treatments are time dependent. So time is important to your cardiac patient, time is important to your stroke patient. Many hospitals are certified stroke centers. Rapid transport is vital. Seizures and altered mental status may also occur. So seizures may occur as a result of a recent or prior head injury, can be a brain tumor, can be a metabolic problem, it can be fever, can be a genetic disposition. Possible causes of altered mental status, and altered mental status is when a patient is behaving in a manner that we would not consider to be normal. And that can be caused from intoxication, head injury, hypoxia, stroke, metabolic disturbances, and because many things can cause altered mental status, the treatment varies based on the cause. Let's review the anatomy. The brain is the body's computer. It controls breathing, speech, and all body functions. There are 3 major parts: the brainstem, cerebellum, and the cerebrum. The cerebrum is the largest part of the brain. The brainstem controls the most basic functions: breathing, blood pressure, swallowing, pupil constriction. The cerebellum controls muscle and body coordination, walking, writing, picking up a coin, playing a piano. The cerebrum is divided into the right and left hemispheres. Each control activities on the opposite side of the body. So the right hemisphere control movement on the left side of the body. The left hemisphere control movement on the right side of the body. The front of the cerebrum is responsible for emotions and thought. So it controls emotions and thought. The middle controls sensation and movement, and the back processes sight. In most people, speech is controlled on the left side of the brain. So the left side of the brain controls how we interpret and how we interpret and how we understand speech. The right side controls how the speech comes out. Messages sent to and from the brain travel through nerves. 12 cranial nerves run directly from the brain to parts of the head, eyes, ears, nose, and face. The rest of the nerves join in the spinal cord and exit the brain through a large opening in the base of the skull called the foramen magnum. At each vertebra in the neck and back, 2 nerves branch out, the spinal nerves. These carry signals to and from the body. And that's the review. Now let's focus on the pathophysiology. Many different disorders may cause brain dysfunction, may affect the patient's level of consciousness, speech, and voluntary muscle control. The brain is very sensitive to oxygen, glucose, and temperature. Now, what you need to remember is if an issue or a problem is affecting the heart and lungs. So if there's an issue with the heart and lungs, the entire brain will be affected, right? If the initial issue or problem is in the brain, then a part of the brain will be affected. So if the heart and lungs is compromised, the entire brain will be affected. If the issue is inside the brain specifically, then a part of the brain will be affected. Sorry. So the general rule, if a problem is caused primarily by disorders in the heart and lungs, the entire brain is affected. If the primary problem is in the brain, only part of the brain is affected. Now, the first issue we're going to look at is headache or headaches, which are very common. So headache, one of the most common complaints, it can be a symptom of another condition or a neurologic condition on its own. Only a small percentage of headaches are caused by serious medical conditions. And you have tension headaches, migraine headaches, and sinus headaches. These are the headaches that you need to be familiar with at your level as an EMT. So tension headaches, migraines, and sinus headaches are the most common. They are not life-threatening. The tension headache is caused by muscle contractions in the head and neck, and it is usually triggered by stress, and the pain is usually described as a squeezing or dull pain or as an ache. And usually tension headaches doesn't require medication to relieve that discomfort, right? So that's a tension headache. The migraine headache is caused by changes in the size of the blood vessels at the base of the brain. It can be experienced by adults and children. The pain is usually described as pounding, throbbing, and pulsating. Persons usually describe it as starting from the one area of around the eye and then spreading out. It is often associated with nausea and vomiting and may be preceded by visual changes, can last several hours or days. Now, then you have your sinus headache, which is a headache with cold-like symptoms. So it's caused by pressure building up in the sinuses, which are there to affect how our speech sounds, and also they help to trap particulate matter. So caused by pressure, that is the result of fluid accumulation in the sinus cavities. Patient may also have cold-like symptoms of such as nasal congestion, cough, and fever. Pre-hospital emergency care, not necessary. Serious conditions that include headache as a symptom are hemorrhagic stroke, brain tumor, and meningitis, which is inflammation of the meninges. Be concerned if the patient complains of a sudden onset severe headache or sudden headache that has associated symptoms. That could be a hemorrhagic stroke. And they usually complain of the most severe headache they have ever had in their entire life. Suspect stroke in patients with severe headache, seizures, and altered mental status. Increasing ICP may be caused by hemorrhagic stroke, tumor, or recent head trauma. Now, stroke, also referred to as a cerebrovascular accident. This is interruption of blood flow to an area of the brain. Can be caused by a clot, or it can be caused by a blood vessel that ruptures. So you have ischemic stroke and you have hemorrhagic stroke. It results in a loss of brain function. Lacking oxygen, brain cells stop functioning and begin to die within minutes. So it's the same problem as the cardiac cell. The brain cell becomes ischemic, ischemia leads to infarction, infarction leads to necrosis. Once the brain cells die, not much can be done. These cells don't regenerate. So brain cells develop ischemia, causing them to stop functioning properly. It may take several hours or more for cell death to occur. That's infarction. With prompt restoration of blood flow, the cells will not die and function can be preserved or restored. So time is brain. And the common practice in Jamaica is granny or family member don't look like them okay, right? You see something look off, the face look lean to you. Granny no look right, or mommy no look right, Make we give them little minty or some bush tea there. Make we watch them and see what happen. Then hours pass and granny or family member decline. Then you decide to take the person to the hospital. At that point, there's nothing the doctors can do to restore function. So patient ideally needs to get to the hospital within, I would say, 3 to 4 hours of the onset of symptoms for the stroke. That's going to give them the best chance of restoration, or they're going to have permanent damage. So there are two main types of stroke: ischemic, which is the one that is as a result of a clot, and hemorrhagic stroke is the one in which a blood vessel ruptures. High blood pressure that's uncontrolled can lead to that, especially if the person is drinking heavily. So ischemic stroke, most common, account for more than 80% of strokes. It results from a thrombosis or an embolus. By now you should know the difference. A thrombosis forms in the area. An embolus is a clot that travels from one part of the body to another part. Symptoms may range from nothing at all to complete paralysis. Atherosclerosis in the blood vessel is often the cause, just like the MI. Start off with the atherosclerosis. So atherosclerosis, plaque forms inside the walls of the blood vessel and may obstruct blood flow. Eventually, it causes complete obstruction of an artery, and depending on which area of the brain is affected will dictate the type of signs and symptoms that you will see occurring. Now, hemorrhagic stroke accounts for 13% of strokes. Results from bleeding inside the brain. Cerebral hemorrhages are often fatal. So it's not common, but it's very deadly. People at high risk includes those experiencing stress or exertion. People at the highest risk are those who have very high blood pressure that is not being controlled. And it will stem from an aneurysm, because the uncontrolled blood pressure over time is going to lead to a weak area in the vessel, and then it ruptures. So aneurysm, swelling or enlargement of the wall of an artery resulting from a defect or weakening of the arterial wall. Now, symptom may be the sudden onset of a severe headache. When a hemorrhagic stroke occurs in an otherwise healthy young person, it is likely caused by a berry aneurysm. So it's an aneurysm, a weak point that ruptures. Surgical repair may be possible if care is sought immediately. Time is hard, time is brain, time is important to these patients. Transient ischemic attack. So a TIA is a patient that presents with stroke-like symptoms, but within 24 hours, they disappear. So it's as a result of inadequate blood flow to an area of the brain, but it restores over time, and then the symptoms go away. However, it is a warning. So it's a warning sign that this patient is at risk for a massive stroke. So TIA, transient ischemic attack. When blood flow to the brain is obstructed due to atherosclerosis or a small blood clot, the patient may exhibit signs of a stroke. When stroke-like symptoms go away on their own in less than 24 hours, the event is called a TIA. Not actual death of tissue. Sorry, no actual death of tissue occurs with a TIA. You may get there and the symptoms have subsided. The patient still needs to go to the hospital to be evaluated. Symptoms of a TIA can last up to 24 hours, may not be able to differentiate between a stroke and a TIA. Every TIA is an emergency, may be a warning sign that a more significant stroke may occur in the future. All patients with a TIA should be evaluated by a physician. Now, signs and symptoms of stroke. Facial drooping. Sudden weakness or numbness in the face, arm, leg, or on one side of the body. Decreased or absent movement and sensation on one side of the body. Lack of muscle coordination, which is ataxia. So when they try to walk, they are not walking steady, they are drifting to one side, right? They have what is called unsteady gait or issues with their balance. There is sudden vision loss in one eye. They can have sudden vision loss. They can have blurred or double vision, can have difficulty swallowing. They can have decreased level of responsiveness, can have speech issues, right? They can have issues with their level of understanding, how they interpret the speech. They can have issues with how they produce speech, how the speech sounds when it comes out. They can have issues naming objects, and they can be able to name an object but not be able to use the object. So there's a wide range of signs and symptoms that can occur with stroke patients. Now, aphasia, difficulty expressing thoughts or inability to use the right words. That's expressive aphasia. So the person who has expressive aphasia is having issues with thoughts and using the appropriate words. The receptive aphasia is the person that has difficulty understanding spoken words. And slurred speech or dysarthria is an issue on the right side. Issues with aphasia, whether it's receptive or expressive, is going to be the left side of the brain. Sudden severe headache, confusion, dizziness, weakness, combativeness. They can be restless. The tongue can lean to one side. They can be found in a coma. As I said, there is a wide range of signs and symptoms to look for. However, there are three Well, 4 things you need to consider. 1, when was the last time the patient was seen normal? 2, does the right side of the patient's face or body matches the left side? Right, so you need to check speech, arm drift, facial droop, and time. These are important. So let them bring the arms out, palms up, eyes closed, and watch if one side drift down or if they can't move one side. Give them a simple phrase to speak. Can you repeat this phrase for me? Today is a sunny day. So it's either they will say to you, today is a sunny day, which is slurred speech, or they're gonna say, I had some KFC, right? So it's either they're having an issue with the left side of the brain or the right side of the brain. Right side is how the speech comes out. Left side is how they interpret speech. They need to look at time, facial droop, arm drift, and speech. Come on, move forward. All right, now the left hemisphere. Stroke in the left cerebral hemisphere may cause aphasia or aphasia, the inability to produce or understand speech. Speech problems can vary widely. Stroke may also cause paralysis of the right side of the body. That's left hemisphere. So when you're studying, pay attention to what you need to look for if it is the left hemisphere. Pay attention to what you need to look for if it is the right hemisphere. So if it's the right hemisphere, stroke may cause paralysis on the left side of the body. Usually the patient can understand language and they are able to speak. The issue is the words are slurred. The patient may also have neglect. So neglect is common when the right side of the brain is affected. So basically with neglect is like they forget that the left side of their body exists. Neglect and lack of pain cause many patients to delay seeking help. Now, bleeding in the brain, patients may have high blood pressure and it may cause, maybe the cause of bleeding. It may be caused by the bleeding as a compensatory response. Increasing blood pressure is an important sign. Significant drops in blood pressure may occur as the patient condition worsens, and that's never a good thing for a patient with a head issue or brain issue. Monitor the blood pressure for changes. Now, conditions that can mimic a stroke. A patient with a low blood sugar, which is hypoglycemia, this patient can present with stroke-like symptoms, but they are not having a stroke. Their blood sugar is just too low. The postictal state of a seizure, after a seizure. This is when the brain is starting to reset. During this phase, the patient can present like they're having a stroke. Subdural or epidural hematoma or bleeding. Blood near the skull presses on the brain. These patients can present as if they're having a stroke. Now, seizures. Not widely understood in terms of its pathology, but generally speaking, seizures affect the electrical activity of the nervous system that is going to the muscles. So something is interfering with the firing of the electrical impulses to the muscle, and you get this abnormal movement of the body. Doesn't necessarily have to create a movement of the body, can be the patient's level of consciousness changes briefly and then the brain chips back in. and there is no physical movement. So seizures, neurologic episode caused by a surge of electrical activity in the brain, can take the form of a convulsion, or it can be associated with a temporary alteration in consciousness. There are two basic groups. You have generalized and you have partial, which is a focal seizure. Now let's look at generalized. Used to be called grand mal seizures. It results from abnormal electrical discharges from large areas of the brain, typically characterized by unconsciousness and a generalized severe twitching of all muscles lasting several minutes or longer. It may simply be characterized by a brief lapse of consciousness. Does not involve any change in motor activity. Right? So that's a generalized seizure. So with generalized seizure, the patient is going to lose consciousness. So there's a loss of consciousness, and you will get abnormal muscle movement. You're going to see that abnormal muscle movement that affect the entire body. So it's either they have that loss of consciousness with the abnormal movement affecting the entire body, or there is a brief lapse of consciousness and then the brain chips back in. So can be the level of consciousness changes briefly and then boom, the brain chip backs in. Now let's look at a simple partial seizure. Right? Simple partial seizure. With a simple partial, let me backtrack a bit. Okay, yeah. With a simple partial seizure, which used to be called petit mal seizures, there is no change in the patient's level of consciousness. Once there is a lapse in consciousness, that's a grand mal or generalized seizure. So there, with a simple partial, there is no change in the patient's level of consciousness. They may have numbness, weakness, dizziness, visual changes, unusual smells and tastes. They may have some twitching or brief paralysis. Now, it can be a simple partial seizure, or it can be a complex partial seizure. With a complex partial seizure, there is an altered mental status. The patient is not unconscious or unresponsive, but the level of consciousness is altered. So complex partial seizures, altered mental status is going to be present. Result from abnormal discharge from the temporal lobe of the brain. You might see lip smacking, eye blinking, isolated jerking. They may complain of unusual odors, visual hallucinations, uncontrollable fear, repetitive physical behavior. Now, an aura. Patients may experience an aura prior to a seizure. It can be something that they see visually or hear, or they get an unusual taste, but something happens and they know that they're going to have a seizure, especially patients that have been diagnosed with epilepsy, which is a seizure disorder. People with a history of seizures recognize their auras and usually take steps to minimize injury. Auras do not occur prior to every seizure, and not all patients with a seizure disorder will experience an aura. So you have your typical presentation and you have your atypical presentation. That's medical emergencies. Generalized seizures are characterized by a sudden loss of consciousness, chaotic muscle movement and tone, so abnormal contraction, abnormal relaxation, and during this time, they are not able to breathe properly. May exhibit bilateral muscle movement characterized by a cycle of muscle rigidity and relaxation, usually lasting 1 to 3 minutes. The patient can present with tachycardia, hyperventilation, especially in the post-ictal state when the brain is trying to reset, sweating, intense salivation. Most seizure disorders will last, or I should say most seizures will last 3 to 5 minutes. The post-ictal state is usually 5 to 20 minutes, and this is where the patient starts to regain consciousness. Now, what typically happens is patient gets a seizure, generalized seizure, then the seizure stops, then they regain consciousness. That's what typically happens. You can have a patient in which they get a seizure, they go into the post-ictal state where the brain starts to reset into this deep sleep state, but they don't regain consciousness, and then another seizure occur, post-ictal state, doesn't regain consciousness, another seizure. So the patient can be getting seizures, post-ictal state, seizures, post-ictal state, without regaining consciousness. This is what we refer to as status epilepticus. Now, absent seizures. This one you will see more in your pediatric population. So with an absent seizure, there is a brief lapse of memory, or a brief lapse of consciousness, and it's very difficult to pick up because it presents that way. So what could be happening is the parent tell the child to pass a book on the table, and bring it to me. And the child takes up the book, and midway in walking towards the parent, the child loses consciousness and collapse, or they might be standing and the brain just chips out, and then they start walking forward, but they don't remember what they were doing, right? They can't recall what was happening before. That's an absent seizure. Status epilepticus. Seizures lasting more than 5 minutes are likely to progress to status epilepticus. But more importantly, is it a seizure in which the patient is not regaining consciousness? So seizures that continue every few minutes without the person regaining consciousness or last longer than 30 minutes are referred to as status epilepticus. So these patients will need medication to stop the seizure. Now, causes of seizures. You have quite a few causes. It can be congenital, where they have epileptic issues or epilepsy. Can be a structural problem, tumor, infection of the brain, scar tissue, head trauma, stroke. Can be a metabolic issue, not enough oxygen, imbalance of chemicals in the blood sugar is too low, drug overdose, sudden withdrawal from alcohol or medications. Or they have a very high fever that is rising too quickly, and it causes febrile seizures. So some seizure disorders are congenital, Others may be caused by high fever, structural problems in the brain, or metabolic or chemical problems. Epileptic seizures usually can be controlled by medications, and these are some of the medications: Keppra, Dilantin, phenytoin, phenobarbital, Tegretol, Depakote, Topamax, Klonopin. These are some of the medications that these patients will be taking. Useful information for you to write down in a notebook somewhere. Causes of seizures. Seizures may be caused by abnormal areas in the brain, structural causes such as a benign or cancerous tumor. Benign is a tumor that doesn't spread. Cancerous is the one that spreads. An infection, it can be a brain abscess or meningitis, scar tissue from some type of injury that affects the brain. Now, continuing with the causes, seizures can occur from metabolic cause, such as abnormal levels of blood chemicals, hypoglycemia, poisoning, drug overdose, withdrawal from alcohol and drugs, prescribed medications. Seizures can also result from sudden high fevers, particularly in children. Doesn't mean that you will only see febrile seizures in children. It can occur in adults. Now, importance of recognizing seizures. Recognize when a seizure is occurring and whether this episode differs from the previous one. Patient may turn cyanotic, especially pediatric patients. Seizures may prevent the patient from breathing normally. Remember that the muscles are not working properly during this time. So if it's a pediatric patient that relies heavily on their diaphragm, they can have significant breathing problems. Now, patient with diabetes, the blood glucose level may decrease and they might need glucose to bring it back up. If the blood glucose level is treated, then the seizure will stop. If protocol allows, monitor blood glucose level after a patient with diabetes has a seizure. Look at other problems associated with seizure. Patients who have fallen during a seizure may have a head injury. Patients having a generalized seizure may also experience incontinence. Now, the postictal state. After a seizure, the muscles relax, becoming flaccid, and breathing becomes very labored. This breathing pattern helps to reduce the acidity in the bloodstream. With normal circulation and liver function, the patient will begin to breathe more normally within minutes. And this is the phase that we will provide all the necessary treatment for the patient. So we do not restrict motion of a patient that is having a seizure. So you don't try and restrict their motion. They can't control it. You can't control it physically. So let the seizure happen. You will have your window to work. When you get that window, if you need to keep them on them side, turn them on the side. If you need to clear the airway, clear the airway. When they're having a seizure, do not put anything in their mouth, right? So don't put anything in the mouth. Don't put any boot over them nose. Don't beat the patient with any Bible. These are things I have experienced in my career. Don't do it. If you've never seen somebody have a seizure before, you can get very nervous, and the natural thing for us to do is immediately grab the person, right? Follow the person in the environment. If they're on a stretcher, you may have to loosen up some straps. Just ensure that they don't roll off the stretcher, and that can be dealt with fairly easily without restricting the muscles of the patient. Come on, move forward. Hold on. Now, may be characterized by hemiparesis resembling a stroke, so they can show signs and symptoms of a stroke during this phase. Most commonly characterized by lethargy and confusion. The patient may be combative. Be prepared for these circumstances. The patient condition does not improve. Consider hypoglycemia or an infection. Now let's look at syncope. Syncope. Seizures often mistaken for syncope or fainting. Fainting typically occurs while the patient is standing. Seizures may occur in any position. Fainting is not associated with a postictal state. Now let's look at altered mental status. So this is a patient who is behaving in a manner that we would not consider to be normal. Aside from stroke and seizures, the most common neurologic emergency is an altered mental status. The patient is not thinking clearly or is incapable of being aroused. In some cases, the patient will be unconscious. In others, the patient may be alert but confused. Causes of altered mental status. It can be the blood sugar is too low. So patient can have signs and symptoms that mimic stroke and seizures if the blood pressure is too low. They can have hemiparesis. A patient who has had a stroke may be alert and attempting to communicate. A patient with hypoglycemia almost always will have an altered level of consciousness. Patients commonly take medications that lower blood glucose level. Patients can also experience seizures. The mental status is not likely to improve even after several minutes. Consider hypoglycemia in a patient who has EMS after an injury, such as a motor vehicle crash. Now, delirium. Delirium is a symptom, it is not a disease, and it presents as a new complaint. So it's a temporary state that may have a physical or mental cause, such as infection, changes in medication, or hypoxia. So they're exhibiting abnormal behavior. It may be reversed if we treat what is causing the issue. Signs and symptoms. Rapid alteration between mental status. Symptoms may mimic intoxication, drug abuse, and severe psychological disorders. Causes of AMS. Considerations of other possibilities become important because a patient with AMS may be combative, refuse treatment, and transport. In most cases, a patient who appears intoxicated is intoxicated. And they're always going to tell you that they didn't have more than 2 drinks, just 2 drinks. Psychological disorders and medication complications are possible causes. Infections, particularly those involving the brain or bloodstream, may cause AMS. Now, patient assessment. Scene safety. Dispatcher may be able to provide a description of the patient's problem. Patients with AMS may exhibit a wide range of signs and symptoms and behaviors. Do not be distracted by seriousness of the situation or frighten family members. Consider the need for spinal immobilization or restriction. For the mechanism of injury or nature of illness, look for clues to determine the NOI. Special considerations for patients with suspected neurologic emergency. An evaluation of the environment for signs of potential trauma is important. Indications of previous medical condition. Evidence of a seizure. Ask family, when was the last time the patient appeared normal? Very important. After the scene size up, it's your primary assessment. Look for and treat life-threatening conditions. Perform a rapid exam. Ask as you approach the patient important questions. Gather information on the scene. Note the patient's body position, their level of responsiveness or consciousness. What is the initial impression? right? How important is that to the patient presentation? Um, did a seizure took place? What is the patient's AVPU? What is the patient's GCS? These things are going to be important. Assess airway and breathing. Patients may have difficulty swallowing and choke on their own saliva. Be prepared to provide suctioning. Position the patient to prevent aspiration. Check for foreign body obstruction. Assess the patient's breathing. All patients with an AMS, regardless of the cause, should receive oxygen. Ventilate the patient at a proper rate with proper volume. Deliver each breath during a period of 1 second at a rate of 10 to 12 breaths per minute. That's if you need to do rescue breathing. Do not hyperventilate the patient. Hyperventilation may have negative consequences, can decrease cardiac output, can put the patient at risk for aspiration, and it can cause a rise in intracranial pressure. Hold on. Okay. Circulation. Check the pulse if the patient is unresponsive. If no pulse is found, you know you need to do a CPR. Use AED as soon as possible based on your current guidelines or protocols. If the patient is responsive, determine if the pulse is fast or slow, is it weak or strong. Evaluate the patient quickly for external bleeding. Transport decision, establish priorities based on your patient's LOC and ABCs. If the patient is experiencing a stroke, rapidly transport to an appropriate facility. In the history-taking phase, investigate the chief complaint for unresponsive patients, gather any history you need from family members or bystanders at the scene. No one is around, quickly look for explanations for the AMS, stroke, hemiparalysis, or one-sided weakness, seizure, incontinence, or biting the tongue. Ask a responsive patient what happened, evaluate responsive patients' speech. Gather your sample history. Time is important. Time is brain, time is heart. Try to determine the exact time the patient last appeared healthy or normal. Collect or list all medications. Ask if the patient has a history of seizures. Ask if this episode differs from previous episodes and what medication is the patient on. If not a serious condition, should be suspected. In your secondary assessment, physical examination, full body secondary assessment, paying special attention to system involved. If you suspect your patient is having a stroke, direct particular attention to your neurologic assessment. So you know you want to check time, you want to look at facial droop, you want to look at arm drift and speech, right? Based on your guidelines or protocols. Definitely want to be paying attention to the GCS, and you want to check PMS in all 4 extremities. Vital signs. Significant intracranial bleeding leads to a great deal of pressure in the skull, compressing the brain. Slow pulse and causes erratic respiration. That's your Cushing triad. Blood pressure is usually high to compensate for poor perfusion. Unequal pupil size and reactivity indicate significant bleeding and pressure on the brain. If the patient has an AMS, check the blood glucose level, check the pulse oximetry, check the pupil reaction. During most active seizures, it is impossible to evaluate vital signs, and this should not be your priority, right? We wait until the seizure stops, then we start to do what we need to do. In most cases, Vital signs of a patient in post-ictal state will be close to normal limits. Stroke assessment rapidly identifies stroke in the field with a stroke scale. Stroke scales evaluate face, arms, and speech. Can be the Cincinnati pre-hospital stroke scale, can be the Los Angeles pre-hospital stroke scale, it can be the 3-item stroke severity scale. Look at the level of consciousness, arm drift, motor function, and gaze. Your department or organization will decide which type of stroke scale you use in the field. Fast mnemonic is important. So regardless of the type of stroke scale you're using, these are things that you should always ensure you look for if you suspect stroke. Facial droop, arm drift, speech, and the time when the patient was last seen behaving normal. GCS is a must, right? So every patient, you need to get a GCS, but it is absolutely essential for patients with altered mental status. Very important. Learn your GCS scale. Reassessment, focus on reassessing the ABCs, vital signs, and interventions. Stroke patients can lose airway or stop breathing without warning. Interventions, multiple interventions may be necessary. So you may have to use airway adjuncts, you may have to provide positive pressure, you may have to administer suctioning, depends on the patient presentation. Compare baseline information with updated information. Notify receiving facility of the patient's chief complaint and assessment findings. Communication and documentation. Call a stroke alert to designated stroke centers. Be sure to communicate the time that the patient was last seen healthy, findings of your neurologic examination, and time you anticipate arriving at the hospital. For patients who have had a seizure, give a description of the seizure activity if known. If the patient has a history of seizure activity, determine how often the seizures occur. If there is a history of status epilepticus. Document interventions and the patient's response. That's a patient assessment. Now let's look specifically at emergency medical care for the various conditions. Some conditions are easy or easier to identify. Cause of other neurologic emergencies may not always be clear or obvious. ED physicians determine if there is bleeding in the brain for patients with suspected stroke with a CT scan of the head. Blood clot dissolving medications may be given if there is no bleeding, but this has to be done within a specific time frame. And the medication is at UE. Notify hospital staff. Treatments are available if started right away. Communicate the last time the patient was known to be well. Time is brain, time is heart. Time is important to these patients. Patients who have had a seizure require definitive evaluation and treatment. Supplemental oxygen, strongly advised if needed. For patients who are having a seizure, protect them from harm by clearing the environment that they're in. You may have to follow them sometime. And you do not restrict muscular activity. Once the post-ictal state is initiated or starts, this is where you're going to focus on clearing the airway, ensuring they're breathing okay, giving oxygen if it's necessary, providing stabilization if required. For patients who continue to have a seizure, as in status epilepticus, when they're in the postictal phase, clear their airway. If they need ventilation, you do it in that phase. They're going to require rapid transport, and they will definitely need ALS intervention. So they are going to need medication to stop the seizures. For headaches, most headaches are harmless and do not require emergency medical care. You should be concerned if the patient complains of a sudden onset of a severe headache. A sudden headache with fever, seizures, altered mental status, or following trauma is also a red flag. For migraine, always assess the patient for other signs and symptoms that may indicate a more serious condition. Give oxygen if it is required. Provide a darkened, quiet environment. Do not use any lights and sirens for these patients. Can actually make the migraine worse, and it can trigger seizures in these patients. For stroke, support the ABCs and provide rapid transport to a stroke center. Patient may require manual airway positioning. Use suction as needed and monitor the patient's oxygen saturation. Give oxygen if it is necessary. And low flow would be more suitable. Oxygen therapy, not recommended unless the patient is in respiratory distress or is hypoxic, just like a cardiac patient. If it's not necessary, don't give it. And if you have to give it, consider starting on the low end than the high end. Paralyzed extremities require protection from harm, and basically you transport them on the side that is paralyzed or not moving. Keep the patient informed. Thrombolytic therapy may reverse stroke symptoms if the patient gets to the hospital in a timely manner and they are within that time frame where treatment can be effective. Spend as little time at the scene as possible. Stroke is an emergency and time is brain. If possible, transport to a designated stroke center. The patient may be in a postictal state upon your arrival. The patient may still be having a seizure. Continue to assess and treat ABCs and try administering oxygen if it's required. It is difficult to safely prepare a patient for transport who is having a seizure. Assess for trauma, use spinal motion restriction or immobilization if necessary. Never attempt to restrain a Not every patient who has had a seizure wants to be transported, right? Your goal is to encourage a patient to be seen by a physician. Be prepared to discuss the situation with hospital staff. For altered mental status, signs and symptoms vary from simple coma. AMS is always an emergency that requires immediate attention. Even if the cause appears to be intoxication or minor head, that would be your neurologic emergencies.